Okay. Hi, everyone. So welcome to this episode of the Referrology series on asthma. Today, we are very fortunate to have Dr. Andrew Lee, who's a respiratory and intensivist physician. At the same time, also, he is an excellent clinical educator and a great inspirational personal mentor to myself. So without further ado, let's talk about this case scenario. So Mr. A is a 23-year-old gentleman who was admitted for 3 days of shortness of breath, some URTI symptoms as well. Of note, he was found to be wheezing on presentation. And on further history, he recalls having some possible childhood asthma, but otherwise has been pretty well over this couple of years with no nocturnal symptoms and no activity limitation. He was admitted to the general medicine team and was labeled as for possible viral bronchitis versus an asthma given this possible history. Was treated with a short course of bronchodilators, steroids, and recovered well. So the first question is in terms of diagnostic-wise. Of course, we would take a good history, try to find out other precipitants and things like that. But for the first question on spirometry, does this gentleman require a spirometry?
Okay, so in the acute setting, generally these patients will have difficulty completing a spirometry. So ideally, we would want to wait we definitely need to do a spirometry at a later stage once he's recovered, because you want to demonstrate reversibility on the spirometry to have a diagnosis of asthma. Asthma's diagnosis is actually a clinical diagnosis coupled with the need to demonstrate reversibility on a series of either on spirometry or a series of other type of challenge tests, such as the Methacholine challenge test, which you have mentioned, or even an exercise challenge test. So usually we don't do it in the acute setting because if they are very breathless, there's no way they're going to be able to do a good, adequate spirometry. Number two, if they are actively wheezing, you may show obstruction, but does the obstruction signify that this is COPD versus is this asthma? Because it may not demonstrate reversibility during the stage of acute exacerbation.
Got it. So roughly how long after the discharge should this be done?
It varies. There's no hard and fast rule, but generally we will discharge them and see them about 4 weeks later, and we will repeat the spirometry then. Viral bronchitis is still definitely possible, but up to 30% of all these patients, when you do a spirometry, actually shows reversibility, and therefore they are actually the first presentation of asthma.
I see. And just another question on spirometry. For asthmas, do we need to trend or routinely check their spirometry after they have been confirmed diagnosis of asthma?
Okay, controversial.
Okay.
That is the setting of repeat spirometry. Probably you don't need to trend it. Okay, that will be the honest truth. It is more useful in patients who have chronic asthma. You want to see whether it's their FEV1 decline, or in COPD patients where you're actually looking for a similar trend. So upon initial diagnosis and over the course of a few years, you may not need to. Having said that, there has been suggestions in the GINA guidelines that you may want to follow up with the annual spirometry just to see the FEV1 change. Because in patients who are not very well controlled, but there are poor symptom, okay, I will rephrase the statement. If they perceive symptoms poorly, means that they may be breathless, but you don't really know it, but yet your asthma is poorly controlled, that can manifest on the spirometry. That is the reason why they do suggest regular spirometries. In fact, actually, GINA may suggest annual. So it depends on your clinical context. Most of the time, we don't really do it annually.
Got it.
It's usually more in the setting of chronic asthmas or chronic obstructive asthmas with irreversibility or COPD patients.
Which patients do we end up sending for a Methacholine challenge?
Usually, a Methacholine challenge test requires you to the first thing you must make sure is that they don't have contraindications, and one of them is actually the FEV1 must be not less than 60%. If not, they are at risk of a very severe attack exacerbation.
I see.
So usually, the group of patients we do this is actually patients who have normal spirometries, whom we want to rule out asthma. Its value is more in the patients who is more in the ability to rule out asthma. So young patients who breathless, who had complained some breathlessness, maybe a little bit of symptoms with that may suggest asthma, but their spirometry is completely normal. Those group of patients, you can go ahead with the Methacholine challenge test.
Okay, thank you. So this slide, as you mentioned, the importance is to demonstrate variable expiratory airflow limitation, and that's why we do a spirometry to look for reversibility of obstruction. Do we still do PES, or has that fallen out of favor?
Kind of fallen out of favor because it's very subjective. It depends on the technique of the patient and it may not be consistent.
Got it. Okay. So we move on to a slightly different case. This is a 24-year-old foreign worker with a background of history of asthma since his teenage years. So in this current COVID era, he was found to be COVID positive with shortness of breath for 3 days, some cough and some wheeze. His x-ray was clear and severity markers were favorable. On further history, he actually says he gets about 1 to 2 exacerbations a year, and they are usually precipitated by URTIs episodes. He is taking PRN Ventolin and it's actually pretty well in between the episodes, and gets an occasional course of steroids from the OPS during these URTI flares. So maybe before we talk about how we manage this patients, I understand that the 2019 GINA guidelines suggests no longer for a role of SABA only treatment. Would you like to comment on this?
The reason is because they believe that if you leave only SABA treatment, these patients may have some underlying inflammation, or they may be even poor symptom perceivers. So that's the reason why they end up with increased risk of exacerbations and lower lung function, simply because you have not done due diligence to reduce the inflammation in the airways. That's the reason why they advocate inhaled steroids as the mainstay of treatment.
Got it. Okay. And moving on to the next question, there's been quite a bit of hype recently looking at how the GINA guidelines have moved, as well as some of the emerging medical literature on Symbicort or Budesonide-Formoterol, as well as its role for smart therapy. Could you share with us what's the reason for this and maybe some of the recent studies that have been done?
Okay, so basically in the past, Symbicort has always been used at your GINA stepladder 3. That's where you have a combination of LABA and inhaled steroids to improve exacerbation rates. However, interestingly, what they find is that formoterol's onset of action is actually quite similar to that of Ventolin. So some very smart people decided to do a study to do something called the smart therapy, where they use Symbicort as both a reliever and a preventer. And they actually found that it was very effective. So that's why they are using Symbicort on a daily basis. And if during this period of time, if they are very smart, if the patient is cognizant and aware and trained, whenever their symptom control is poor or they may have a mild exacerbation, they can use an additional puff. They can use up to 12 puffs a day. That is what smart therapy is. So using the same principle, because it can act as a reliever, the question is that whether you can use it just as a reliever itself in patients whose asthma control is actually, whose asthma is actually very mild. So if you go and look at the latest papers in NEJM on Symbicort, they were using it predominantly as a reliever with inhaled steroids during the period of exacerbation and not on a routine basis. Okay, and that was where the hype came about. It has shown that it was effective in reducing exacerbations, although symptom control-wise may not be as good as that of inhaled steroids. But overall, there was a decrease in exacerbations. If you think about the purpose of inhalers in asthma, the intent is actually to reduce exacerbations. That's why inhaled steroids is your first line of treatment. So you give a little bit more inhaled steroids during each exacerbation. It probably has shown some good efficacy in reducing exacerbations while the symptoms will not be as well controlled. That's why people have started advocating this.
Okay, but just, so thank you for raising that point, but I was just wondering if, let's say, still having a regular ICS still gives better symptom control.
Oh, definitely.
Yeah, why is it that for even up to step 2, the recommendation still promotes quite highly just PRN ICS Formoterol?
No, so if you look at are we able to show the GINA table? If you look at the GINA table, okay, the GINA table actually doesn't state the Symbicort in the box itself. It's actually stated below as a suggestion.
I see.
It's different. You can do it, but it is not the overarching vasoconstriction.
Okay.
Yes. So your preferred reliever is as needed. But if you go and look here, there's a star. Data only for Symbicort and is all S. If you go and look at the original papers, the papers were saying it's mild intermittent asthma. That was the inclusion criteria.
Okay.
So that's why they say start here if symptoms less than twice a month, if more than twice a month, less than daily. But these don't completely always fulfill the criteria of intermittent asthma. That's why it is all.
Okay. This is a good segue to actually going back to how you would choose to manage this particular patient. The question I wanted to ask was then, would you give like a Symbicort PRN or still give some form of regular ICS? Because in the ward setting, most of the time what we have noticed is generally we still try to give patients a regular ICS, especially when they're admitted for an exacerbation. Would that be a good rule of thumb?
Yes, I'd rather start them on regular ICS first, because you don't really exactly know for this group of patients whether their control actually has been really that good and it's very mild intermittent asthma. It'll be very bit difficult to tell, especially if they don't recognize it. So we will usually advocate that first, and then we will reassess again later on.
Okay, so you can always have the option of stepping back subsequently lah.
Yes, possible lah.
Okay, sure. Yeah, so maybe later on as we talk about the next case, what I hope to find out a bit more is, so we have this set of guidelines or recommendations here from Gina. We have this table that tells us what is low, medium, and high dose. And then we have this whole host of inhalers. And I guess the struggle for residents is that, yes, we have these recommendations, but how do we practically make decisions when there are so many options? So maybe for the stage 1 and 2s, is generally Symbicort currently the preferred choice, or do we still give some patients PRN SABA or like low dose beclomethasone, which used to be pretty what is done in GPs and polyclinics?
Sure. So I think we have to take this. Let's look at it from this table, and basically when we choose an inhaler, we will have to look. We will base it on this table. Number 1, in terms of this issue about their potency. Number 2, the other considerations are what are the patient's premorbids, and whether the patient's inhaler technique can be considered depending on the device. Okay. Now, why I say this, if you can go to the next slide of the different type of inhalers. No, the next one. Yeah. If you look at it, there are many different devices which require different type of inhaler techniques. So if you want to choose an inhaler, you must know what your purpose of the inhaler is. In asthma, is basically prevent exacerbation. Moving forward, then you will need to see if this patient is able to use the inhaler, meaning can they coordinate. Stroke patients will have difficulty coordinating. Patients who are weak, neuromuscular weakness, may have difficulty doing a good inhalation or forming a good mouth seal. Or maybe some patient may have RA hands, gout, and they cannot do a turning. So therefore, like acuhalers, they are unable to do a good turning. So from this, you can make a judgment and assessment which device would suit the patient. If the patient cannot coordinate, whether you need an aero chamber. Then after that, the purpose, and then if we go back to the Gina step ladder, you will determine at what stage this patient is, and you'll choose the appropriate inhaler. If it's ICS LABA, it can be a serotype with an MDI, with an aero chamber, or if the patient is very good, sometimes patients may choose to use an acuhaler, versus whether the patient has a good inhaler technique and they can use a turbohaler with the Symbicort. Now, the Symbicort now has a Repihaler, which is similar to that of the MDI, so that can help with some coordination if necessary. And of course, the important thing is that the third important thing in Singapore in particular is that cost is an issue. So with the SDL2 subsidies available, things like serotype, Symbicort are all subsidized. Whereas your combination ICS, LABAs like Flutiform, they are not subsidized. So that's why people will make a choice based on cost too. And this is very important in Singapore because the subsidies can be as high as 50%.
So comparing beclomethasone with a SABA, which is what a lot of the patients previously were on, compared to Symbicort, would the cost difference be very significant with the subsidies considered?
May not, but then that again go back to the principle of what's the intent of the inhaler. Okay, giving repeated SABAs versus giving some low dose inhaled corticosteroids to reduce the exacerbation has difference in outcomes. So I think one of the other things you rightfully pointed out, maybe you can go to the next slide on potency.
Yep.
Okay, if you can see that we have low, medium, and high potencies. If you look at your original genus step ladder, they advocate low potency until step 3.
Yep.
Okay, and only after step 3 will you go out to medium potency. So it is important to remember that if your low dose inhaled corticosteroids are ineffective, adding a LABA is more effective compared to increasing the steroid dose.
Okay.
Okay, and the reason is because if you draw a table of amount of steroids versus the amount of efficacy, it actually plateaus off as it reaches the medium to high dose. So that's why giving very high doses of inhaled steroids may provide only minimal benefit. And that's the reason why that's why when you look at this, the way I remember is I just remember the medium doses. And then after that, I will know roughly how much inhaled steroids I'm giving. If it's not effective, I just go straight to a LABA. And only after it's fully controlled on step 3, that's where the respiratory physicians had to start talking about whether you want to add a LAMA, whether you want to give oral steroids. These require specialist evaluation and assessment.
Okay, thank you. So you've probably answered a bulk of the questions relating to the next case. So the next case is actually someone with kind of established asthma who doesn't seem to be under very good control. It's her 4th exacerbation this year, and she's on serotype 50, 25, 2 puffs BD, still getting both some nocturnal and daytime symptoms, as well as some allergic rhinitis. Her compliance is good, and her technique is actually competent. So I think you've answered some of these questions, but I guess the questions that people face on the ground would be, okay, in terms of the ICS, do we increase the number of puffs, or should we switch to a different preparation or a different steroid completely? Especially some of these patients may have a couple of inhalers at home because they may have gotten, like, let's say, 6 months worth of medicines. You've answered the question about adding a LABA. So the takeaway that I've gotten is that it is better to add a LABA rather than push the steroid doses too high. And I guess the last question would be, do we switch those patients who were previously on the SABA, beclomethasone to a Symbicort? Perhaps you could answer the first question first about ICS. What do we do? Do we increase number of puffs with the same inhaler? Do we change to a different preparation, or is there any role in changing to a different steroid?
Okay, this is physician-based practice, so there's no hard and fast rule. Okay. But how I would see this is that I would look at the different devices the patient has. You don't really want a patient to have 3 inhalers, all of which require different devices and require different inhaler techniques. Yep. It's usually simpler to make sure that they have one similar type of device and use that accordingly. Whether you want to change the inhaled steroids to another steroid is very physician dependent. Usually, I don't. Okay. As I said, the potency question and whether is it low, medium, or high dose comes into play here. Because if you increase the ICS, maybe can we go back to the table?
This one?
Okay, it's not here. So basically, if you imagine serotype has about 6 to 8 different formulations. There's 50-25, there's 25-125. Basically, it tells you the amount of Spirometry to the amount of steroids fluticasone present. Yes. Now, it is important to remember that when we adjust this, the Spirometry dose can go only as high as 100 mics. Anything more is out of the boundaries of is considered drug overdose, essentially. Okay. So that's where it comes back to the question of whether it increase puff or not. It depends on the device, it depends on the amount that you're giving, and also depends on safety. So in serotype in particular, people often forget the Spirometry component and just think of increasing the steroid component. Okay, got it. Answer your 4th question. Then I will add the caveat that it depends on the understanding of the patient. The elderly, if they are not as well educated, they may not understand the purpose of maintenance and use only when exacerbation.
Okay.
So usually this can be done among the young, because they are a lot more aware of what's going on. So it really is dependent on patient education and understanding.
Okay.
Predominantly more understanding. Yeah.
The next question, do you give LTRAs and methaxanthines, or is this not so favorable?
I don't usually give.
Okay.
But the Montelukast, okay, I would say that generally is an adjunct. Okay, you can try if you have not achieved adequate control, but usually by the time you don't achieve adequate control, you need to go through your whole algorithm of why control is poor despite being on a LABA ICS combination.
Understand.
Yeah.
And if you give Montelukast, how do you usually dose it?
You just give it's one tablet. I think it's 10. Yeah, it's one tablet every night.
Okay. And it can be given as something long term, or do people use it in
People
short?
can give it as a long term.
Okay, sure. Thank you very much. And methaxanthines generally not really lah.
It's fallen out of favor because it's a narrow therapeutic index.
Okay.
Yeah.
Thank you. You've answered the top question already about beclomethasone, salbutamol. You've also answered the question about the cost profiles. Just an interesting question. Do we hold beclomethasone Formoterol in Singapore? I understand that there is a Beclo rather than Budesonide-Formoterol formulation. To your understanding, do we have it here?
Not in NUH lah.
Okay, sure.
Yeah, not in NUH.
Okay. The next question is about counseling regarding relievers. So I think you pointed out just now that for Symbicort, we can give up to 12 puffs. How do we counsel about these 12 puffs? Is it 12 puffs in succession, 12 puffs in a day? What exactly do you tell patients? And likewise for, let's say, Ventolin.
Okay, so for Symbicort inhalation in a day, usually if it's a smart therapy, I advise them that you will take your usual doses for prevention as per normal.
Okay.
If you do develop an attack, you can take an additional 1 to 2 puffs to relieve your exacerbation. Okay. And the number 12 is the total number of puffs that you take throughout the entire day. So meaning if you take 2 puffs in the morning, 2 puffs in the evening, on a regular basis you take 4 puffs a day. If you take an additional 2 puffs in the afternoon because you were breathless that day, that's 6. Okay. So you can take up to 12 per day.
That's it. And but beyond which, then they should be seeking medical attention.
I think if they take that 12 in the I think it's also clinical context. You take 12 in succession in the morning, you better come to hospital.
Yep. Okay. And for Ventolin, how do you normally counsel? Like, what's the max number of puffs they can take? Actually,
we don't really counsel them on the maximum number of puffs. So you must remember, the GINA. If you look at the GINA guidelines, there's something called a GINA control score. So you can give. If you use Ventolin at least twice, okay, you would actually be it means that your asthma is partially controlled. And so those are things already that would ring alarm bells to us already.
So generally, we tell them if there's an increase in use, then they probably should be seeking medical attention.
Oh yeah, definitely.
Okay, rather than specific numbers.
Yeah, we don't really spell a specific number actually.
Okay, thank you. The next question is, so this was taken from the GINA guidelines about short-term increase as part of asthma action plan, like during sick days when they have URTIs and things like that. What struck me was that the suggestions were actually quite significant increments of dose quadrupling. Based on your experience, how do you normally advise patients in terms of dose increment for ICS during their sick days?
Dose increment for ICS, actually we don't.
Okay.
We actually ask them to take their ICS as per usual, and you take the steroids and you use your Ventolin. If the symptoms still persist, so there's something called asthma action plan that we will teach the patients, where we teach the patients to what to watch out for, what to do when you have an exacerbation, and if they remain uncontrolled despite all this, despite all these interventions, that's when they come to hospital.
Sure. So you don't, as part of the action plan, tell them like, hey, if you have a bit of URTI symptoms, you can bump up your ICS.
Oh no, we don't. In fact, actually, there's been some studies that showed among kids that shows that it has no difference. So it's controversial. I know that in the GINA guidelines at the end, they actually mentioned you can bump it up for maybe 2 weeks. But more and more people are starting to have reservations about it. I know that there are still certain physicians who do so. I think that's fine. But it's starting to become controversial.
Okay, thank you. The last question that we have for this asthma episode is about the content and composition of nebulization during an acute exacerbation. Maybe you can comment for both asthma and COPD. I guess the question is, number one, do we always give salbutamol with ipratropium? Does the ratio really matter?
Okay, so usually you want to give SABA. So usually the thing can go up to about 4 mils within that little canister. So usually the routine one that people will do is actually 1 mil of salbutamol to 3 mils of normal saline.
Okay.
So it helps to nebulize and then it inhales and reaches the distal airways. You will use a combination of salbutamol and ipratropium in severe exacerbations.
Okay.
Because it has shown some synergistic effect, even though we do know that the cholinergic tone in asthma is not high. Okay. Now the controversy, the difficulty sometimes happens that when you do neb salbutamol, they tend to be tachycardic. And so when you become tachycardic, you keep giving the nebs, you can cause the tachycardia to persist. Some of them, if they have AF, it may even be worse because they will continue to their AF may run amok. So what at least I personally sometimes do is I take off the salbutamol and I give the ipratropium instead.
I see. This is in the context of asthma.
In the context of any obstructive airway disease exacerbation that has persistent tachycardia and the AF is like running at 150s, 160s, you may want to try to reduce the salbutamol component and then still help to relieve with ipratropium. But like I said, this is a physician practice. There's no EBM behind this. This is a pathophysiology assessment and we'll move forward.
And does the same, what you have just mentioned, apply to COPD as well, that we normally just give a SABA first? Or
no. So COPD different. COPD people, because you know that there's some anti-muscarinic, there's a lot of anti-muscarinic agents available, so it's the same thing. When you give ipratropium, it has its anti-muscarinic effects.
Okay, thank you. Okay, so we've come to the end for the asthma episode. Do you have any take-home points with regard to the management of asthma for our residents?
So I have I do have a few. So the first point is that the diagnosis of asthma requires both a clinical assessment of symptoms of varying duration and intensity. Okay, their intermittent periods of being well, coupled with a spirometric assessment of reversibility. Okay, Methacholine challenge test can be done but it must be done in safe settings and is usually done to rule out rather than diagnose. That's usually the situation that we do it in. Okay. The second point I would talk is about inhaler choices. Please, I think the important message is that inhaled corticosteroids is still the mainstay of treatment. There are a lot of all these fancy ideas of how to make things life simpler and easier, but it has to be taken in the clinical context. So inhaler choices, please remember the principles behind it for asthma and how to choose an inhaler. I will reiterate the 4 principles. 1 is the intent of the inhaler. 2, the device. Okay. 3, the patient's comorbidities. And 4, the patient's understanding. And sorry, 1 more, which is the finances in Singapore. Okay. All this coupled with the fact that you need to assess control, which we didn't touch upon, but I'll just reiterate there's a GINA control score that looks at 4 symptoms: daytime asthma symptoms of more than twice per week, any nighttime awakening due to asthma, any Ventolin use for symptoms more than twice a week, and any activity limitations due to asthma. Okay, you can use the ACT or the ACQ, but that is usually the GINA guideline is quite practical on a day-to-day basis.
Got it.
Yeah. So these are the 3 main points. And last point, anyone who has come in for what sounds like asthma essential or viral bronchitis still does need a follow-up to just make sure you assess them for asthma, because up to 30% of them actually end up as being the first presentation of asthma rather than just viral bronchitis.
Okay, thank you very much. Last question on viral bronchitis. Do we normally give steroids for viral bronchitis?
Physician preference.
Okay, sure. Got it. Okay, thanks a lot, Dr. Andrew. Thank you.
No